Recording. I think hello.
Yes, he is. The
Okay.
record this is on.
So I think so as much as possible, I'm just going to make this discussion to be interactive. So we know all this. So don't intend to go through all this. These are basic form of ECG that we are quite used to. And we know all these. We know a good Q wave. And so I just wanted to look at this. So what do you think is the ECG we're looking at? Like I said, it's going to be an interaction. So of course, I won't be discussing ECG from beginning, just to flag some things before us, for us to be able to remember some of the ECG we've already seen before. So I'd like someone to try and make an attempt to look at the ECG we have on the slide. So what do you think is ECG?
Okay, let me try. This I'll come to the rhythm later, but there's P wave in front of the curve, except that the P wave axis is negative here, which I think is part of the issue. Then the axis is extreme right axis. When I look at the precordial leads, in terms of the R wave, there's inverse R wave progression. Not the typical R wave progression that we'll get. That's R here. By the time you get to V6, there's no R. And in V1, in lead 1, there's negative P. The P wave is negative. QRS is also negative, and the opposite is happening in AVR. But the T wave, yes, but the T wave here is positive. That's yes. So when I put things together, I think this may be a dextrocardia.
Okay. And any other comments from anyone? Pardon me to call some people to come around and help us out. Like I said, this is just going to be interactive class because we are specialists, and I'm sure that we know some of these things. It's just to flag it up so that as you're going for the exam, it could be very handy. So that's the purpose of this section. So we don't intend to start teaching ECG from the beginning. So Mohammed, do you agree with what Dr. Aposa said?
Yes. In addition, V4, V5, V6, and AVL, AVF. They also have low voltages.
Okay. So we shall further confirm that
most likely is dextrocardia.
Dextrocardia. So that's correct. So if you look at the ECG, you're almost seeing a reversal of what you see.
Okay.
Hello.
Sorry, sir. I wanted to, before you, Dr. Waller said about low voltage. I don't know. Are you V5, V6, low voltage? Is it because of the negative deflection? I don't know to put now.
Is it why you have low voltages?
It said the V5, V6, they have low voltage and AVF. That's for that confirmed dextrocardia. I was thinking that because of the poor R wave progression instead. I don't know whether you can use that the same way, voltage and power wave progression.
Potentially, so the cause of the poor arrow wave progression is because of the reversal of the heart, because the heart is on the right. Remember that the reason why you have poor arrow wave progression is progression from the right to the left, because the left tend to do more of cardiac activity, so it tend to be higher. Because you are having dextrocardia, there is basically no contractile activity from the lateral leads. You get my point? So either way you look at it is correct, whether you look at it from the perspective of poor arrow progression or you look at it from the perspective of low voltages. The low voltage really is really marked in V4, V5, VVF, because these are the leads that look at the heart on the lateral side. And on the lateral side, where you should have the left ventricle, it's being reversed to the right side of the heart. So you're having reduced electrical impulses. Hence, the amplitude of QRS deflection is also reduced. So either way, I think it's correct that you look at it from the perspective of.
I understand the way you are coming from. I understand where it's clear. Thank you, sir.
All right. Yeah. Okay, so just bear that in mind. Dextrocardia, this is it. So I'm sure we can look at for the differentials and discuss what follow. Okay, so quickly, just flashing the ECG before us. What do you think is this? So who's going to help us? Anyone?
Maybe I will try.
Yeah, please.
Okay. For me, sir, this is a sinus reading.
This is a sinus reading, okay? Tell me, what's your evidence for sinus reading?
Because every QRS complex preceded by every P wave is preceded by QRS complex. I see the P wave there, then I see the QRS complex.
Okay.
Okay. But one thing I also notice here is that they don't look like a delta wave. They don't look like a delta wave. So I'll see that. And then the PRO server here appears short. Yes, PRO server appears short. There's data with that of story. And so I would think that this
is what?
Wolff-Parkinson-White syndrome.
PWPW. Okay.
Yes, sir.
Any other comment to this? Any other comment?
Hello, sir.
Yeah,
Good
I can
evening.
hear you. Good evening, Dr. Percy. How are you?
I'm fine, thank you, sir. Yeah. So I'll rather say WPW pattern because there was no history given.
Yeah.
You call it syndrome when the patient has symptoms in association with the ECG findings. So being no symptoms yet, I'd rather call it a pattern.
Okay.
WPW pattern.
Okay. That's okay. So I think any third person, any other comment from anyone?
Hello, good evening, sir.
Good evening.
Good evening, sir.
Good evening.
So I think the type A with the PR wave in V1 being positive, and also the QRS.
Okay. Any other comment? So that I think the main thing is that, yeah, I agree with all of you. The last person make it more specific to A. But I think the most important thing in case of exam is that keep it simple. If you could say type A, that's fine. That means that you must differentiate it from type B. But what is usually is that remember that you must have an evidence before you make your diagnosis. So state your evidence. Evidence is because you could see a delta wave, the slowing of initial wave before the arrow wave, and a short interval P wave. Okay, and because you have a positive deflection in the B1, so that tends to tell you that this is A. So yeah, I think the point here is that there's accessory pathway somewhere. So with the history, you could make your diagnosis. Remember that on the cardiology scenarios, they're going to give you clinical scenarios, so there'll be an history, there'll be investigation, ECG will be there. So it's for you to put all your information together and make a diagnosis. And usually the next question will be, how will you investigate? How will you treat the patient? So keep that at the back of your mind. Okay, I won't say too much about this. I won't say too much about this. So what do you think about this ECG? Who is there? I think I would suggest that whenever you see an ECG, either you raise your hand or unmute your mic and start talking, because the exam day you will talk by default. So if I were you, I would rehearse before the exam day.
Yeah, good evening, sir.
Yeah, good evening.
Yeah, so this ECG is showing lead through. There is AV dissociation as evidenced by the regular PP interval and dissonance, and also the changing PR intervals. And also the complex, the QRS complex looks narrow. So putting this together, I would say this is a complete AV block with supraventricular escape reading.
Okay, kind of junctional escape reading.
Junctional escape reading.
Yeah, good. I think this is really straightforward. Like you said, the PR interval, the P wave, they are regular with regular QRS complex intervals, which are independent of each other, a kind of dissociation between the P wave and QRS complex. Yeah, with narrow QRS complex, which tells you that these complexes are coming from the upper part of the AV node. So yeah, junctional escape. So treatment, one treatment for a patient that what the treatment? Just state the treatment, not stories. What will you do for the patient?
Permanent pacemaker insertion.
Permanent pacemaker insertion. Brilliant. So what do you think?
Sorry, I'll take you back. And I don't know.
You can take me back.
My network cut me off totally here. But for I thought it was a complete hard block. But I heard junctional escape breathing somewhere. I don't know.
So it's a complete hard block, meaning the AV node is blocked. So impulses from upper part of the heart, is not getting to the ventricles. But yet you can see ventricular activity, which is reflected in the QRS complex. So the question is, where is this QRS complex coming from? So because the QRS complex is narrowed, it tells me that this is not coming from ventricle. This is coming from AV node. So the block is more of upper part of the AV node, not the lower part. Because if it's on the lower part of the AV node, you'll see ventricular activities that are broad, more than 120 milliseconds. And those are the kind of patients that tend to go into cardiac arrest because of the ventricular activity. So that's why we say this is a complete AV nodal block with junctional escape rhythm. That is, the AV node is blocked, but just below the AV node, from the bundle of his, they are able to generate impulses that drives the ventricular activity. So we say junctional escape rhythm. So the junction, some readings are escaping from the lower part of the AV node. Remember that the conductive system of the heart, they have that potential to be able to initiate impulses. So by the time AV node is blocked, the bundle of His can start driving the ventricular activity. Does that make sense?
Yes, sir.
All right. So next. So what do you think? Somebody sorrow, just talk. Exam day, this will come up. If they are going for exam, just pick it up.
Yeah, good evening, sir.
Good evening, sir.
So, looking at this ECG, looking at the rhythm strip, lead 2, of course, it's, the axis is normal axis, but looking at the rhythm strip, we can see that it is regularly irregular, and then we can see that the first complex on lead 2, the lowermost on the rhythm strip, the first complex, and then looking at the second complex, there is the PR interval looks different, and also the P wave I don't think is exactly the same. So I will be thinking of premature atrial complex in bigeminy. I want to think that the first complex. Yes, the second beat looks like an ectopic atrial beat, and then the compensatory pulse, and then a normal beat, an ectopic beat. However, what I'm not clear is it seems after the ectopic beat, there is after the QRS complex, there is a deflection that looks like a P wave or retrograde P wave.
Which of them now? You're looking at the reading strip, right?
Yes, the reading strip.
Is it this one you're talking of, or this?
Yeah, that's the QRS complex. Then after it.
Yeah, this is what you're talking of.
Yes, yes.
So this is a pause.
Okay.
I know I'm asking you. I'm not just saying what it is.
Yes, that's supposed to be the compensatory pulse.
This compensatory pulse. Okay, so you're saying that this is premature atrial complex.
No, the second bit.
This is premature atrial complex.
Yeah, that's what I think, sir.
So how do you know the one that's normal and the one that's abnormal?
Well, the one that has the compensatory pulse after.
That's the abnormal.
Yes, sir.
Okay. Let's hear from. So you think this is what's your final diagnosis?
My final diagnosis is premature atrial complex in bigeminy.
So bigeminy.
Like
So
I said,
atrial bigeminy. That's what
yes,
you're referring to.
atrial bigeminy.
This
Yes,
is
sir.
definitely not ventricular bigeminy.
Yes, sir.
Okay, let me try.
Let's hear for someone else.
Okay, let me try. I think this is Mobitz type 1.
Okay.
AV block evidence by for the first bit, when you look at the PR interval from the first and the second bit, the second one appears prolonged. Then after the second QRS, there's a deflection, which I think is a P wave, and that is not followed by any QRS.
So you're talking of this. Are you talking of this?
Yes.
This is a P wave. Okay. So this is the PR interval you're talking of. This is the prolongation you're talking of, right?
Yes.
This is P wave. So yeah.
No QRS complex follows it. Then
Okay.
a PQRS starts with the PR interval that is shorter than the last one observed, as in the second complex.
That's this one.
Yes. So that qualifies for a Mobitz 1 AV block.
Okay. Can we have a third opinion? Amount of 2 or 3. We have 2 motion on the ground right now.
So I'm thinking of Mobitz 2 because the PR interval seems to be constant from the first wave and to the second wave, the second one, then there's a drop with the third one. So the third QRS again, there's a P preceding fourth, there's a P preceding the fourth wave also. The third, there's a drop. So it looks like Mobitz 2 with a 2 to 1 block.
Okay. But you said the PR interval is constant. I can see
It looks constant. Yes, sir. It is constant. Yes, sir.
This and this. Just thinking. PR interval. Compare this to this. And this to this.
They're not constant.
They are constant. So we'll have 3 people now saying 3 different.
So I'm saying it's not. I think I agree with Dr. Gordon. A sort of prolongation until there's a drop it to qualify for Mobitz type. Welcome back.
Yeah. I would think so too. I would think so because if you look at this PR interval, this is definitely not the same with this. Sorry, let me bring my so it's definitely not the same with this. Even the PI segment is longer than this PI segment. So any different opinion on this? So I think I will agree with Mobitz type.
But sir, if I may, as first speaker who talked about premature atrial, has talked about premature atrial contraction, PACs. I do agree that there are PACs here. Because also for opinion.
You didn't agree that PAC is there?
Yes. No, sir, it's you. I don't know if you agree that
whether there's a PAC.
Yes.
So if you look at the impulses here, look at these impulses, and look at this. In terms of the heart, they are not even the same. They're looking different. QRS complex and these are looking different. So remember that if you have Mobitz type, Mobis type 2. Did you say Mobis type 2? Gordon, did you say Mobis type 2?
No, type 1.
Type 1.
One.
Yeah.
It's one.
Thank you.
This one is okay, yeah. So it's because there's a progressive prolongation before you have a drop. Again, remember that if you look at the impulses, electrical activities of the heart, the reason why you have different deflection in terms of the heart, it depended on the electrical impulses. It's also dependent on where the impulse is coming from. If you look at the P wave also, the P wave morphology, they're not looking the same all throughout. So is either coming from the SA node, is either coming from the atrium. Sometimes because the heart is trying to generate impulses from the SA node, as a form of automaticity. And because of the AV nodal block, the impulses that are coming up is progressively blocked until there's a drop. The heart begins to send impulses everywhere. Why am I not getting enough from the SA node and all that? So sometimes the atrium can also initiate activities. And these different automatic focus of the atrium can give you varied morphology of P wave, as well as varied morphology of the QRS complex. If the PI interval were normal and you don't have a drop, you can begin to think of atrial bigeminy or atrial trigeminy, as the case may be. But here you could see that what gives it away, whenever you just see regular reading, you look at the PR wave, there's a progressive prolongation of the PR wave with a drop. That just tells you that this is Mobis type 1. But if you are dealing with atrial complexes, or you are dealing with atrial bigeminy, you don't expect to see that prolongation. Potentially, these P wave and chaos complex will have been initiated from the atrium because of the varied morphology of the P wave and the chaos complex. But beyond that varied morphology, you can see that there is progressive prolongation of PR interval with a drop, which tells you that for whatever reason, for whatever the impulse is coming from, whether the SA node or the atrium, whether you have atrial complexes, the patient has some kind of AV nodal blood, which is progressive. I don't know whether my explanation is making sense. Hello?
Yes, please.
Yeah, it makes sense. Does it make sense?
Yes, please. It makes a lot of sense.
All right, thank you.
Please, if I may also add, so the strength with Mobits 1 is with the fact that the new beats, the PR interval is always less than that of the one that ended the cycle. So when you're in doubt, just check this new one. Let's say the third beat in this rhythm, the third beat, compare it to the second beat.
That's you're talking of this one?
Yes.
Compared to this one?
Yes. So that's the most the easiest way to go about it. So once you see that, because at times you may not even see the progression. The progression may be so small that you may not appreciate the progression. But once it's progressing small, and many bits are coming in, what it means is that they'll be added. So between the very first one and the last bits, you can really see the PR interval difference. So it's always good to compare the one that is starting it and the last one that ended the bit. And also my comment on the premature atrial contraction will be that, so for premature atrial contraction, the compensatory pulse is not fully compensated. So what it means is that when you look at the rhythm strip here, beat 1, beat 2, beat 3, where we missed it, you can actually tell that the next beat that is coming there is well compensated, and that will speak less for that of premature atrial contraction. Although you get compensated pulse, it's not a perfect compensation. You can actually insert one beat here, and the rhythm will still be fine. So that means that it's not premature atrial beat, since the compensation here, assuming it's premature, the compensation here is perfect, and that is not typical of premature atrial beats. Okay, thank you.
All right. Okay. I think we've done something like this before, so that we can be fast. Yeah, so I'm sure we know all this. So what do you think? So who is talking to us? Dr. Augustine.
I'm still taking a look at it, sir.
You said? You are still looking at it. Okay, please do look at it.
Yes, sir.
Anyone, once you've had enough look, you can take the stage and tell us something. The good thing is the exam day, you won't wait for anyone, you do it anyway. So just get used to it.
Hello, good evening again.
Good evening.
So just
yeah. Go ahead.
Yes, you can see there is AV dissociation.
Mm-hmm.
And then looking at the QRS complex, is wide this time, is broad this time, looks broad. So this is complete AV block with ventricular escape reading.
So this is complete heart block, you mean?
Yes, complete heart block with.
So what's the evidence for it?
There is complete AV dissociation.
Okay.
As evidence by you
So
can see that
one P wave, another P wave. P wave is here. P wave is here. P wave is somewhere around here. P wave. So the P wave is regular. Is that what you mean?
yes, sir. Fairly.
Okay. Yeah. Okay. Do I agree with that, or is there any other comment? Do we agree with that? Dr. Henry? Dr. Bassi, Dr. Abibola, Dr. Faye Chikani, Dr. Afiam Bassi, Cassidy. What do you think? Do we agree with that? Is there something more on this ECG? Hello. So what do you think of the lateral lead one? What do you think of the deep S-way in V1, V2, V3?
Okay. So there are deep S wave in V1, V2, V3.
So what do you think of that? This. What do you think of the axis? It's definitely ventricular bradycardia. Yeah, I quite agree with you that there are elements of complete heart block with junctional escape breathing. But again, if you look at the S1, you got some deep V1, you got some deep S wave, 2, 3. Then you could see the pattern in lead 1. So this patient, apart from having complete heart block, this patient has some form of LBB. Okay. Any other
Yes,
finding?
I was thinking the broad complexes are ventricular, the escape rhythm, the ventricular escape rhythm. That's why we have them broad like that.
If you look at that lead 1 in particular, so there's a notch. So, which also tells you that apart from the AV node being blocked, there are also some form of left bundle branch block in this ECG. Yes, so if you look at these other ones, look at these, these are a bit narrowed. So, which again tells you that this might be coming from the bundle of his or upper part of the AV nodes. But again, if you look at lead 1, you could see some, apart from being broad, you see the notching of the QRS complex, which tend to, lead 1 and especially lead 1 and AV they are regarded as the high lateral leads. So they tend to look at the lateral aspects of your heart, towards the base. So yeah, definitely this patient has some form of left bundle branch block beyond the complete heart block. That's because of the deep S wave, broad QRS complex in lead 1 with notching. You can also see some of those stuff on lead 3. Okay, how did we get here? All right. Because of time, I have a lot of ECG on this stuff so that we can just go through as much as possible. We've done a lot of block. What do you think is this? Hello? Are we still awake?
Yes, sir.
Yeah, so what do you think? Just assume that you want to report this ECG. So what's the first thing that strikes you?
The first thing that strikes here is that the RR interval okay. First thing that strikes here is that there are no discernible P waves. I can't fully make out a P wave here, sincerely. Oh,
What
sorry.
of this?
Sorry.
What of this?
No,
What
no,
will you
no.
say is this one?
Sorry,
What will you
sir.
say is this one?
But if you look at that lead 1, there's some places that don't have P waves.
Lead
So
1. Okay, here.
I've seen that one.
This one
But
has, this one doesn't have.
the other ones don't also have.
But
Okay,
again,
so
it's always good to look at reading stream.
yeah.
You can see also this one doesn't have, this one doesn't have, this one doesn't have, this
But
one doesn't have. So let's assume that this patient P wave represent impulses from the SA node atrium, and then you see QRS complex. Then you see another one that appears to be short anyway, the PR interval. And this is almost close to the QRS complex. And here you don't see anything. But you can see a deflection coming after, which looks like a P wave coming after the QRS complex. And then you don't see any P wave. Then, this looks like P wave. QRS complex. You can't see any P wave. No P wave. Something coming after the QRS complex that look like P wave. Of different morphology. And then you see another annoying, tall, almost peaked P wave. Then another P wave again. Can't see any good P wave. So what do you think? First, I can see that it appears that we're having multiple P wave, different morphology, different sizes, coming at different time of the QRS complex. Right?
Okay. So, boss, is this multifocal atrial tachycardia that generates into ventricular atrial fibrillation? Because at a point you're not really seeing anything at all.
Yeah. But again, can you say this is tachycardia? Is it's more than 100 if you look at the rhythm?
Okay. So it's just about. I'm struggling to see the lines properly, but it's just around.
Just around, right? Yeah. Just around. So one feature here is that you're having P wave of different sizes, different morphology. So it tells you that it's coming from different focus, which is in keeping with multi. So MAT does happen in the context of most of the COPD, but once the heart rate is less than 100, you tend to say this is Wondry pacemaker beat. But if his heart rate is more than 100, that's what you define as multi-atrial tachycardia. Like you said, some instances you don't even have P wave, so which again can also explain the fact that it degenerates into some form of paroxysmal atrial fibrillation. And if you look at the period where you don't have P wave, you could see a notch after the QRS complex right here that look like a P wave, which again tells me that could this be coming from the junction with a retrograde P wave? But again, we expect that to be inverted. Again, you're seeing something that look like a P wave coming after the QRS complex. So maybe it could be the timing, the timing between the impulses is conducted through the AV node and the junctional rhythm. So I think one thing clear here in this ECG is that you're having multiple morphology of P wave, which does define the fact that is coming from different sites, the ECG. And if you look at this other part, you can see some ventricular complexes. Again, so so if the heart rate is more than 100, it fits perfectly into multi-atrial tachycardia. But if it's less than that, you tend to use the word Wondry pacemaker. Okay, any question on that? I'm sure they won't bring this kind of research in anyway. More respiratory. I know we know these. We know these. Okay, so what do you think? Hello? Are we still there? Hello?
Yes, sir, we are here.
Yeah, Mohammed, I've not heard your voice after the first time. Mohammed, are you there?
Yes, sir, I'm here, sir.
I thought you were sleeping already. So tell us. So what do you think? Is there really strip? There's no really strip, really.
Yeah, that's what I'm looking at.
Yeah, there's no really strip. That will give some difficulty. But can you make anything out of it?
Well, seems to be ventricular tachycardia. I'm just trying to see if I can see discernible P waves.
Do you think this is ventricular tachycardia? QRS complex look narrow to me.
Yeah, but the P waves I can't really.
Yeah, we can see a very good P wave, right?
P
Especially if you look at the lead 2, for instance, we can see good P wave, but we can see an ST segment, but there's a P wave here. This is a P wave. This is a P wave.
Yes.
This is a P wave. This is somewhere here. So, but there is ST segment depression here, is it not?
Yes.
This is depressed. This is depressed. This is depressed. 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 You can get some P wave, P wave, P wave.
Okay. So
what? Yeah, look at the AVR. AVR is a bit
elevated.
Elevated. Then look at lead 5, lead 6.
Depression.
Depression seems to be everywhere, right?
Yes.
Mm-hmm. The widespread depression.
Yes.
So for a patient to have widespread depression tells me that there may be some form of hypoperfusion for whatever reason.
Yeah.
And if the heart is fast, as it is, this is about 150 thereabouts. Look regular.
150, yes.
Yeah, look regular. So the diastolic function will be affected because the heart is not resting enough
for that.
For diastole to happen, which does perfuse the heart. So the heart may be having some form of hypoperfusion from the fast heart rate as a result of impaired diastolic function. What do you think? Any comments on this?
Okay, so thank you. So as you rightly mentioned, there's widespread ST segments depressions, which are in this case appear ischemic because they are horizontal, and then with AVR there's ST segment elevation AVR. If the tachycardia can actually explain this, but if the history is consistent with somebody we are suspecting is having myocardial infarction, then this will be consistent with somebody with left main coronary artery occlusion or a triple vessel disease, because that gives this classic picture of AVR ST segment elevation and then widespread ST segment depression in the other leads.
Yeah, those are brilliant brilliant differentials. Yeah, that's really correct. Good. Because we're looking at possibilities of what could be causing these widespread problems. And left main disease, especially with the elevation of the AVR, is quite suggestive of that. Any comment from anyone? Okay, let's move to the next one. Yeah, we know this. Tell me. Okay.
So the AVR and left main, estimate AVR and left main. I don't know. I was thinking that the AVR is at the right side. So
AVR is at what?
The AVR and left main disease, the relationship. Just mentioned.
The relationship. So if you elevation, SC segment elevation in AVR is classic for left main disease. And that has to be explained with a lot of electrical activities in terms of direction of impulses. Remember that AVR is the only leads that take a negative deflection, in terms of the flow of electrical impulses relative to the leads. I think there's a lot of electrophysiology discussion that we involve a lot of classes and pictures and explanation and practice direction. But I just keep it simple that once you see elevation in ABR, it does suggest to you that this is involvement of the left main. Okay.
Thank you. Yes, sir. Thank you, sir.
So tell me, what's this? What's this?
That's a normal ECG.
Normal ECG. I just want to be sure that you are not carried away with abnormality. So this is normal ECG. So what's this? Quick one.
Sinus tachycardia.
Sinus tachycardia.
Sinus tachycardia. What's this? Spot diagnosis?
Atrial fibrillation.
Atrial fibrillation is some form of ST segment depression, which again will be because of hypoperfusion. What's this? Spot diagnosis. Dr. Henry. Dr. Henry. What? Tell me. What's this?
Atrial fibrillation.
Atrial fibrillation. So what's this?
To VT.
This is VT. Okay. Why? What's the evidence for VT?
Heart rate is very fast. That I don't know how to calculate it, but it's
So the heart rate
way
is definitely very fast. Yes.
very fast. The QRS complex is also wide. Broad QRS complex, fast heart rate, and of course, no P wave.
There's no P wave here.
No P wave. I'm looking for what they call them now. It's capture beats, or I'm not listening anyway. Or fusion beats. No, not sure.
Caption. Yeah, tell me.
R waving AVR.
Say that again.
R waving AVR.
Arrow wave in AVR. So explain further for me, please.
Okay, so looking at AVR, the deflections there are upright, as in it's R wave, no.
This one, they're upright.
Yes.
Okay.
I think they appear to be negative.
Negative?
Yeah.
No.
Yes. So the axis generally, I think that's there's an inferior axis generally.
Well, but sorry, looking at the rhythm strip down there, it's irregular.
It's irregular.
So,
Brilliant.
So I think it's more of a maybe pre-excited AF or something.
Yes.
Pre-excited AF, yeah.
Yeah, I think I'll agree with the pre-excited AF. Also, there's the concordance here. You can see for V1 is predominantly negative, but for V5, V6 is positive, and that's not typical of VT. VT will do one concordance throughout. So if it's positive, it's be positive throughout, and if it's negative, it will be negative throughout. So this one, you have negative in V1 and then positive in V5, V6. So that wouldn't speak for VT per se. And also the this appears, the axis appears to be an LBB sort of axis, which means that whatever is happening is not coming from the left ventricle. And so unlikely to be a VT also.
Okay, so it's unlikely to be VT.
Yes.
Okay, any last comment from anyone? Dr. Cassidy, Moji Shola, Dr. Labisi. So what do you think?
I agree with the pre-cited AF,
Yeah.
Reading strip, yes.
I think yeah. Thank you. I think the key here is that anytime you see this rubbish, I think the first thing is to look at irregularity. Once it's irregular, think more of pre-excited with SVT with aberrancies, which could be form of LBB or could be form of WPW. But just know that that would be an SVT with aberrancy. The fact that is irregular because the underlying reading might be atrial fibrillation, which is conducted through any of the aberrant pathway. While in the context of VT tend to be regular because the impulses is coming from the ventricle, tends to be of a regular pattern. Most time, that's what helps us to classically look at it, coupled to what other people have also said. So on the go, quickly, you want to look at it, look at the reading. If it's irregular, think of SVT with aberrancy first. Of course, differential can also be VT, but this is unlikely going to be VT. This is SVT with aberrancy. In a clinical situation, if you're confused, it is said that you should treat the patient as a VT. Okay, any query? We can move forward, right? It's okay for us to spend 2 hours, right? By 11 o'clock. Is it okay to stay till 11 o'clock? Go on.
We would have to decide as a group at this point. I think that a lot of people would require more time for personal studies, so I wouldn't want to on them. So if
that's I try not to overload. I could send the slide across for your personal revision so that we don't overload everyone.
Okay, thank you.
At least we've done. You said?
Sorry, till 10:30.
10:30.
People can add the extra left.
Okay. Because so far, I've tried to focus on readings. We've done blocks. We've done atrial fibrillation. So I think what is remaining for us to just focus on ST segment changes. So we use these few minutes to do that, right?
Yes, please.
So I'm sure we know this. Spot diagnosis, fast, no fast, regular, look like flutter wave, right?
Yes, sir.
They are flutter wave. Sometimes you can't differentiate from look like 2-to-1 atrial flutter because of this flutter wave. But sometimes if that is regular, differentials are atrial flutter, SVT, that's AVNRT or sinus tachycardia. But there's no P wave, so that rule as sinus tachycardia. So this could either be flutter wave, which is likely because of the presence of flutter wave 2-to-1 atrial flutter. So again, atrial fibrillation, spot diagnosis. What do you think is this?
Atrial flutter.
Atrial flutter. What do you think is this?
Atrial flutter with variable blood.
What do you think is this?
Looks like atrial flutter too.
Atrial flutter. So, what do you think is this?
This looks like SVT.
SVT. Good. Okay, so this is ST segment changes. So tell me, let's just discuss this within the next few minutes. So what do you think?
Inferior wall stemma.
So what are your evidence?
ST elevation in the 2-3 AVF.
Okay. Please, is there ST segment depression in V2 also?
What do you think? In one V2?
V2. So probably in that case, that would be more like a posterior.
You can also see AVL. See some depression in AVL.
Lead one also.
I think those are reciprocal changes. The inversion in one AVL may be reciprocal changes to the inferior wall elevation, inferior lead elevation.
Okay. Any comments? Any further comments? So remember, they have lateral MI, anterior MI, inferior MI, and posterior MI. So when you say this is inferior, when you say this is lateral, when you say this is anterior or anterolateral, when did you say this is posterior?
So this one, I'll go for posterior inferior because of the ST depression in V2 and V1 also. So it means that the inferior and the posterior segments involved, and in which case, in 85% of the time, that is due to a right coronary artery occlusion.
And if you use the term right coronary occlusion, remember that we have different segments of the right coronary artery. Is it the proximal aspect? Is it the middle aspect? Is it the distal aspect? Even if it's distal aspect, is it involving the PDA? Is it involving the branch to the lateral ventricle? So these are the things that defines it. And also remember that that occurs in up to 80% of the time, but in few patients, the lateral circumflex could be dominant. And if that is also affected, it could be involving the posterior aspect of the heart, but is involving the lateral circumflex as a dominant branch. So what do you think? So so again, sometimes is the evidence the matter, because you can't just make a diagnosis without supporting evidence.
Okay, so
something. Tell me.
Yes, I was going to say that when compare lead 2 and lead 3, the ST segment elevation lead 3 is more than that of lead 2, meaning that it's a right issue, right coronary, not circumflex. Then the other, to tell whether it's proximal or distal, at least there's evidence for distal, but we don't have evidence of proximal involvement until we do the AV, the right-sided one, AVR. I mean, lead 4 right. That one will give us more information as to whether the proximal part is involved, but the evidence is for the distal part.
Yeah, so it's more of a distal part, which again, remember that the distal part tend to supply the posterior aspect of the heart. And here we're seeing a mirror image of ST segment depression in the anterolateral leads. Okay, comment. Comment. Okay, if we're on the same page, let's look at the next one so that we can maximize our time. So what do you think is this? What do you think is this?
There's anteroseptal ST segment elevation with very tall T waves.
Tall and peaked.
Tall and peaked. So this is an acute anteroseptal myocardial ST elevation myocardial infarction.
At least you have V1, V2, V3, or any other differential? Any other differential? Do you want to consider hyperkalemia?
Yes, hyperkalemia also causes peak T waves. But because of the same mechanism, because the reason why for the ischemia or the MI, they get a peak T wave is because there's increased potassium levels in the inside the cell. So if somebody also has hyperkalemia, the same principle is happening. So that can also cause that. So I think the history in this case will help. But with this ST segments elevation, I'll go for the STEMI.
Okay. Any other?
Also, the T wave, the morphology of the T wave in hyperkalemia is usually narrow. It's tall but narrow, but this one it looks more like the hyperacute T wave of ischemia.
Ischemia.
It's broad.
Okay. I think overall, the lesson here is to keep differentials in your mind, and history is usually useful to know exactly what is happening. All right. So, what do you think?
So there's a lateral STEMI, and with reciprocal changes in the inferior leads, and also the tall T waves all the way from lead V2 to V6. So there's lateral STEMI.
I'll say anterolateral.
I'll say anterolateral too.
Yeah, V3 is also ST segment elevation. So the anterolateral, yeah, I agree with that.
So this is what you were talking about, right?
Yes.
Yes, the right-sided.
Yeah, the right side that we're talking of. I will send these slides across anyway, so you could take a look at them in detail. So what do you think here? What do you think?
So widespread ST segments elevation. So and in V6 ST to T ratio is more than 0.25. So in this case, it's likely to be acute pericarditis.
Yeah, agree with you. Acute pericarditis. What do you think? Okay, this is block. We've done this before. Let's just leave it out. What do you think?
So ST segment depressions.
Depression, yeah.
They appear, I don't know if we can describe this as smiley appearance. So that may speak for Jigoxin effect or probably ischemia.
Okay. Straightforward. How do you think?
You're reminding us that we can still have normal ECG.
I still have normal ECG, so that you don't think of normality all the time.
Okay, I think this one we've seen it.
So this is more of anterior MR with inferior changes. So seen something like this
This is the
before.
one we said anterior.
Yeah, we've seen this before. Yeah, I think we've seen this also.
Yes, sir.
So what do you think is this? I think okay, this is better. Let's look at you. What do you think?
This could be Wallen syndrome.
Type B.
That's
Type
one.
B.
Any other one? Any other thing with this patient that you consider?
It's also widespread T-wave inversion, so it can also be hypokalemia.
Hypokalemia. What again? Could be hokum.
Yes,
It could be hokum. It could be subarachnoid hemorrhage.
Yes.
Could be patient with hypertensive cardiomegaly. So just keep differential in his mind. But remember that this is typical of Wellens, and Wellens is suggestive of involvement of the proximal LED. Yeah, just keep that in mind. Stays.
Type A Wellens.
Type E Wellens.
Oh, okay. This
Apart
one
from that, what other thing do you see?
There's actually obvious ST segment elevation. So the context of a biphasic T-wave, that's the reason I mentioned the Wellens. But then this can still pass for a STEMI because there already Q waves are developing in.
There's already Q waves right there. So this could be late presentation of STEMI. Of course, yeah, Wellens is also biphasic Wellens. Wellens could be biphasic. So you think of that. And yeah, so it could just suggest to you that the proximal part of the LED may be involved in terms of trying to categorize the coronary artery that is involved. So these are still T-wave inversion. Just trying to tell you that T-wave inversion might be there. Okay. This is what? Sinus. How's this?
Sinus block.
3, 4, 5, 6, 7, 8. Is it more than 3?
No.
2, 3, 4. So if it's less than 3, that's a sinus pause. More than 3, sinus arrest. Again, we've seen this before. I think we've seen this before. Seen this before. Seen this before. Seen this before. What is this? What is this?
It's a normal ECG.
Normal ECG. Just to remind you, normal ECG. We looked at something like this. Trying to skip some of these arrhythmias. Looked at this before. Looked at this before. It's an SVT. What do you think? I think we've looked at all these. We've looked at all these. Okay, so SVT. So I won't discuss this. I'm sure Vlad may discuss all this in detail. So I'll leave it out. Same here. Same here. I'll send the slide.
Do you have anyone on Brugada?
Brugada. I'm trying to look for it. I should have one, but I'm looking for it.
Yeah, I don't. It's a difficult issue for me. Difficult one every time.
I think Brugada is simple to look at the history, and they tend to have different morphology. Easy for us. Easy for us. Yes. What was this? Remember the other one we looked at the other time? So this is regular, right?
Yes, this is regular.
Mm-hmm. So different from...
It could be SVT with aberrance.
And apart from that, what again? Differential? Could just be an SVT, right? So what do you think? Is this with aberrancy or with an SVT? Is this SVT with aberrancy or just
Yes,
VT?
I said SVT with aberrancy. The complexes appear broad.
Usually you tend to, I think we have up to like 7 criteria that you look at.
Yes.
To be able to differentiate it.
Yes, sir.
And remember the concordance. Negative in V1, V2, but positive in V4, 5, and 6.
Yes, sir.
So you have that 7 criteria to look at it, including capture beat, including fusion beat. That's differentiated
Brugada sign.
Tell me.
Yes, I said Brugada sign.
Brugada sign. So there are lots of criteria to look at. So, but those are the 2 differential. Sometimes you have to do EP studies for you to be able to know exactly the underlying reading.
That is Brugada sign. I don't know why they say Brugada sign. Okay, sir.
There are criteria, Brugada criteria, that's the real word. And it has a lot of criteria to look at, which I can't remember all of them on the top of my head. Or you look at them that is able to tell you that you are dealing with an SVT or you are dealing with VT when you have these impulses. So those are usually the 2 differentials that you have. So the word is, they have a lot of criteria. One of them is the Brugada criteria. You have a lot of parameters to look at. Can't think of I can't remember all of them at the top of my head right now.
So but if I should add, the Brugada sign is you look at the beginning of the R wave to the peak of the R wave, the beginning to the peak. If it's more than 100 milliseconds, then that speaks more for VT. So that's the Brugada sign. You can also look at the entire duration of the QRS. Typically for VT is more than 160 milliseconds, and the non-VT may be less than that. Then as already mentioned, you look at whether there's AV dissociation. If you see P waves along the strip, then it means that there's AV dissociation. You also look at whether there are fusion beats, capture beats. Then the axis is also important, and the other things where the concordance, all those things put together.
And Josephson notch at the nadir, close to the nadir of the.
Yes, Joseph. Okay, thank you.
Yeah, well done. Thank you. So, similar stuff, just to remind us. Yeah, so what do you think this is?
It's too sad.
Okay, how do you differentiate it from this? Did you see it? Look at this one. Let me see the other one. Okay, look at this one.
Yes, sir.
Look at this one. And look at this one. This and this. Is there any difference?
They all look like tossals.
This one tossals. Okay. What is this?
This is looking more like tossals. The first one, well, this one, well, it's looking like tossals. So another differential may be maybe ventricular fibrillation.
Yeah, that's what I would think. I think it's more of ventricular fibrillation. That's a bit chaotic. And if you look at you see the typical twisting around the point. You see, if you look at here, see the typical twisting around the point. But if you look at that here, you can't see that kind of morphology. So this is more of a VF, because they could flag this for you in cardiac arrest. You could paint a picture of a cardiac arrest and flag this and ask whether this is shockable rhythm or non-shockable rhythm. This is to start. We are on the treatment. Magnesium, IV magnesium is the treatment. Okay, so that's everything I have on the ECG. Do you have any question for me? Like we say in the UK.
Sir, in the exams, are you supposed to know everything in the ECG? You know, some ECG can have 5 issues to recognize. Must you know 5, like what ECG will have ST elevation? There can be heart, the same ECG, can have heartburn, can have just like that.
I think I understand exactly what you're trying to say.
Yes.
I think it's just to help yourself see yourself as a clinician, as the doctor. They are not going to give you ECG to just interpret. You are going to interpret the ECG in the context of the clinical scenario. So they'll give you a clinical scenario. Usually what they do, except they change it, sometimes they may just add the ECG. Sometimes you ask for differentials and investigation. If you say ECG is one of your investigation, they'll give the ECG. you interpret it within a few seconds. So you must tie your clinical history with your ECG. But remember that in an ECG, there are major things you're looking at. So you have to report the evidence that supports your diagnosis. If you look at an ECG and there's a complete heart block, definitely is important. You can't leave it out. You must say it. And the way it goes is that the examiners will have looked at it and they will have also decided that for a candidate to score the mark, you should pick this problem. You should pick this problem. So it may not be every problem, but there are problems that you must pick. I would say that if you look at the ECG, just report the abnormality you can see, because you don't know which one will give you the mark. But tie it to your clinical history, not looking at the ECG in isolation. Okay. Any more questions for me? I think we're almost running out of our time. So I saw on the chat that I should send the slide across. I'll definitely do that. I'll send the slide across to you. Dr. Gordon, any more questions? Hello, am I still online?
Yes, please. Thank you.
Okay.
Thank you very much. I'm not
All
seeing any questions in the chat box again.
Yeah. Okay, so from me, I'm wishing you all the best in your exam. I also usually like to take medical statistics. I don't know if do you want us to do that tomorrow, medical statistics?
Okay. Okay, please, I think we would have to
You can stop the recording, yeah.